Hello, everyone. Good morning, good afternoon, good evening, wherever you're joining us from. Thank you for joining us at the Center for Bioethics, Ethics Grand Rounds series. We are very excited to have Dr. Candrian present to us today. For those of you who have not joined us before, our Ethics Grand Rounds series focuses on health equity, and we offer a session each month. I will go through some rapid housekeeping in order to allow Dr. Candrian as much time as possible. I will start with a disclaimer that the views expressed by our speakers are their own and do not necessarily reflect those of the Center for Bioethics faculty. The center does not take positions on specific issues, and the hosting or posting online of a webinar does not imply endorsement of any views expressed by the speaker. As far as logistics for the day, please use the Q&A function if you have any questions, and center staff will be monitoring the Q&A function if you have any technical issues. This session will be recorded and is available at the link you see here, which will also be provided at the end of the presentation today. Captions are available and enabled for this presentation, and we will provide an evaluation. There are 4 ways you can access it. The document that was just posted in the chat the presentations document will have the evaluation present. There is a QR code here available, and in addition, you will receive a link, an email with a link to complete the evaluation after the session. If you are looking for CEUs for today, the presentation details document has a form that you can link. For IPE credit for Minnesota students, there will be a reflection form in the document for you to complete for biomedical engineering. Your Canvas page in the assignment tab will have a bioethics grand rounds attendance, and you can complete that there. All requests for certificates need to be submitted within 1 week of today's date, and you must attend 75% of the webinar to receive credit. We have a large number of co-sponsors for today's presentation. I am not going to read the list, but I will leave it up for just some seconds so everybody can see who is really supporting this work. And without further ado, I am incredibly pleased to present Carey Candrian from the University of Colorado School of Medicine. Dr. Candrian, I could read quite a long bio, but won't. I'll allow her to use her time to share with you. She's an associate professor in the Division of General Internal Medicine and the director of the Science and Communication Lab at the University of Colorado. Carey, Dr. Candrian, I will turn it over to you now, and we'll look forward to our discussion at the end.
Thank you so much, Dr. Nilo Suarez. I will go ahead and share. And then I just trust if you don't see this, let me know.
You are all good.
Well, thank you again, and thank you all for being here. Sure, these are working. I have nothing to disclose. Back in January, when I got an email from Jennifer and Deb inviting me to give this talk, Minneapolis was all over the news. ICE was everywhere, and so were Minnesotans. I've been watching you all for the last months. Your courage, your creativity, your hearts, your tenacity, your refusal to never stop standing up and standing with community. And I'm truly honored to be with you all for the next hour. My work throughout my career has focused on older adults who are LGBTQ. This is a community who knows fear, who knows silence, who knows discrimination, and who knows courage. We are in a new era of don't ask, don't tell for a lot of people, including LGBTQ people. This silence and fear has historically had an impact on healthcare, and not surprisingly, it's getting worse. One thing that has particularly plagued the LGBTQ community is the idea of the single story that has followed them for a lifetime. An idea from Chimamanda Ngozi Adichie, who talks about the danger of the single story. The idea that if you show people as one thing, as only one thing, over and over, That is what they become. We've perfected this with a lot of communities, including LGBTQ people. Historical events have helped reinforce this story and this narrative, a community that was defined as mentally ill up until 1973, a community defined as groomers, perverts, deviants, dangerous, a community to fear, to control, to silence, to make invisible, to literally legislate away. And unfortunately, it shaped how people think and feel about this community. What's so powerful and scary about the single story is how it strips away the humanity, the individual faces and stories of an entire community. For the last decade, I've been focused on breaking open the single story surrounding the LGBTQ community as a way to improve healthcare for older LGBTQ people, especially for those who are dealing with serious illness or end of life. As I'm sure you all can imagine, serious illness and end of life is hard. It's hard for everyone, but it's even harder when you're older and LGBTQ. The obvious question is why? Why is it so much harder? For one thing, they're navigating healthcare with three major disadvantages. The first is discrimination. According to the American Heart Association, 56% of LGBT people report experiencing some type of discrimination from a healthcare professional. The number jumps to 70 for those who are trans or gender nonconforming. At the same time, people who are LGBTQ are disproportionately at risk for a variety of health disparities. They have high rates of cardiovascular disease, certain cancers, dementia, anxiety and depression, and suicide. A second reason is financial. 1 out of 3 LGBT adults live at or below the poverty line. A third, many of them have faced job discrimination for most of their lives. A lot of the financial is also directly related to the fact that many of them have a very thin network of support. They're 2 to 3 times less likely to be married, which means that compared to the general population, more of them are often living and aging with a single income. It also means that most of them are growing old without access to spousal benefits or Social Security, things that can really matter when you age. They're also 3 to 4 times less likely to have kids and more likely to be estranged from the biological family because of rejection. All of this means is that in addition to fewer financial resources, LGBTQ people have less overall help with care, support, and advocacy as they age. Third, and really underlying all of this, is a lifetime of stigma and discrimination, which, according to Harvard Medical Magazine, can take up to 12 years off their life. How does stigma and discrimination have such an impact? Let me give you some context. When I say older LGBTQ people, I'm talking about people who grew up in the 40s, the 50s, and the 60s, when being LGBT was completely taboo and dangerous. It was illegal in most states. People lost their jobs, their homes, their friends, their family. As I mentioned earlier, until 1973, the American Psychiatric Association officially listed homosexuality as a mental disorder. Just imagine growing up thinking that there is something that wrong with you, that you are sick because you are LGBTQ, how much you would internalize that stigma and how vulnerable you would be. And even though the laws have changed, the APA has changed, the stigma has stayed, and so has the fear. And this deeply affects the way LGBTQ people move through the world, what they will share and what they will not. And things right now are not getting any easier. In October of last year, the Move and Advance Project surveyed over 1,000 LGBTQ adults. They found that a quarter of LGB adults and more than half of trans and non-binary adults have taken concrete steps to become less visibly out in their communities, their jobs, and their schools. Some have even moved different states. I know several folks who are actively trying or who already have left the country just to stay safe. And for most of my career, I really wanted to understand what was behind it all, the disparities in health outcomes, the fear, the stigma, and its effect on health, all of it. and what we could do about it. As a healthcare researcher, and like most researchers, I deal with data and statistics a lot. But the numbers can't always tell me why and how some of the things have come to be. So a decade ago, I started doing a lot of qualitative research. I've done over 200 interviews with older LGBTQ seniors about their experiences in healthcare. The more I heard their stories, the more I realized there was a strong connection between communication and health disparities and outcomes. Literally, the way people communicate, the way we talk and listen to each other, can actually make a measurable difference in someone's care. And a huge amount of the way we communicate is directly connected to culture and habits around communication. One of the women I interviewed was Pam. She told me about growing up in New York City in the 50s. She had never even heard the word gay or lesbian. She told me that it wasn't until the 70s that she even had a vocabulary to describe herself. And when she did have a vocabulary, she also realized how dangerous it was to be out. These are pictures from Stonewall. So she stayed silent for years. And when she eventually did come out in her 70s, she was fired from her job as a copy editor. It's no surprise that people who are older in LGBTQ, who grew up in this culture, have honed what I call a habit of silence about this core part of themselves. And they've hid it for their entire life. This woman, Shirley, only came out when she was writing the obituary for her wife of 38 years. She was 81. This habit of silence was and often still is a critical defense strategy, and this habit of silence still exists. It exists in general in all aspects of their lives, but importantly, it also exists in healthcare. 48%, nearly half of LGBTQ people, say their own doctors and those who care for them don't know they're LGBTQ because they're afraid if they share, their care will get worse. Just imagine hiding something so central for so many years. And LGBTQ people are not crazy for staying silent and worrying. Discrimination can and is happening all over the healthcare ecosystem, including places like assisted living and even hospice. In a 2023 hospice survey with over 290 LGBTQ patients and partners, they found that 35% reported their provider being insensitive to them. They found that 30% said that the provider was unaware of their unique needs as an LGBTQ person. 23 reported feeling judged, and almost 20 said that their decisions were actually disregarded. In this same study, out of the 16 discriminatory actions that they reported, 11 of them, possibly more, had the potential to directly impact clinical decisions and care, and all 11 are related to communication. Unfortunately, the discrimination is still happening. In 2024, the Kaiser Family Foundation surveyed more than 6,000 LGBTQ respondents and found that 65% reported some type of discrimination in their daily lives. And no surprise, this discrimination is having concrete effects on their physical and mental health. In terms of physical health, in the survey, 24% reported having a negative healthcare experience. 6 out of 10 said that they prepare for insults or feel like they need to be careful when they go to the doctor, so they're treated fairly. 39% said this made them less likely to seek care. In the same survey, in terms of mental health, 7 out of 10 of the LGBTQ adults describe their mental health as fair or poor. And nearly half said they couldn't get the mental health services that they need. This is a lot of extra work and stress to carry when you're entering the healthcare system. And I know I just threw a lot of statistics at you, which you may or may not remember. But what I would like you to remember is that there are real people behind these statistics. People like this woman, Esther, a woman I met 4 years ago when I interviewed her for my research. Her story and others like hers are the reasons I do this work. When I met Esther, she'd recently lost her wife, Kathy, to cancer. During her illness, Kathy was in and out of the hospital for multiple times. And at first, they were open about their relationship and being a couple. But when they realized Esther and Kathy were a couple, the hospital staff started coming less to Kathy's room, and her care was suffering. So they decided to hide their relationship through it all, through Kathy's illness, her treatment, and ultimately her death. Because they were hiding their relationship, Esther couldn't talk with the care team about next steps or concerns. She couldn't advocate for her wife. She couldn't even hold her hand. Then, when Kathy died, nothing. No one said a word to Esther. They had been together 33 years. I remember when I asked Esther what the hardest part of this whole thing was, and she said, "My wife was dying, and I couldn't even say we were married." Since they were hiding their relationship, what this example continues to show is really how communication affected the outcomes of two people. Kathy didn't have the support or the advocacy she needed from the person she loved because Esther wasn't family. And Esther was shut out of all decisions and decision-making. She had no voice and ultimately no grief support. She was just the good friend and the emergency contact, not a grieving spouse who just lost the love of her life. And it turned out that Esther was so traumatized by this whole experience that she avoided the healthcare for well over a year, even though she had a growth on the side of her neck. So we have delayed medical care on the caregiver as well. Unfortunately, Esther and Kathy's story is not unique. This is a choice LGBTQ people face all the time in healthcare, especially as they age and often end up seeing multiple specialists and doctors. Do I come out and risk being treated badly? Or do I stay silent and hide a fundamental part of who I am? It's a heck of a choice. And on the one hand, we have documented discrimination and disparities in outcomes. On the other, we have people who are understandably worried about sharing this information and who have honed this habit of silence to stay safe. What I'm worried about right now is that the current environment is creating even more fear. And more fear could push even more people into the safety of silence, which could lead to more disparities, more bad outcomes because of communication. But communication is actually one thing we in healthcare can change, and it can make a big difference for people who are LGBTQ. Just think of something as simple as our forms or our intake questions. They're scripted, and sometimes for good reasons. We want to get the information we need, and we don't want to miss anything. But this will not come as a surprise to researchers on this webinar, but the way we frame a question can really impact the answer we get. And for people who are LGBTQ, who are often worried that their care will suffer if someone knows they're LGBTQ, the way questions are phrased can unintentionally shut people out and push them into silence. But with these forms and intake questions, what we really want to know is who? Who is this patient? What do I need to know about them to take the best care possible? And who are their people? Who do they want in the room when we're talking about their care? Who will be helping them at home? And who do they trust to make healthcare decisions if they're no longer able to? Historically, the way we've asked these questions around the who are often checkboxes or fill in the blank, which can literally box people in. So what if, to start breaking some of these scripts, we just started asking, do you live with anyone? Who's the biggest support in your life? And to be clear, it's not only about getting the information, but it's using language that opens up the conversation and takes the limits off of the way people can respond so that they can answer in a way that actually fits them in their life. And these subtle changes to some of our basic questions can actually make a huge difference for people who are LGBTQ. Just imagine the difference it could have made for Esther and Kathy. Another script we use a lot and hear a lot in healthcare is just around family or like a family meeting. But the word family has a lot of boundaries that can box people in or box people out. Countless LGBT people have been cut off by their families. And so if you say the word family, they might only think you mean biological family. It might not share their situation or full information. which means you may not get the information you really need, which is the who. So other ways to break these scripts, to take off the limits are, who do you want with you when we talk about your care? Who will need support so they can support you? And who are your people? Another really important part of healthcare, especially related to serious illness and end of life, are around advanced care planning conversations or goals of care conversations. These are critical tools in medicine because they're basically conversations where people can tell us what's important to them, what they want, and what they don't want. But there may be other things that are also important to the patient, but are not part of our traditional scripts. Let me give you an example. This is Janelle, a woman who transitioned in her late 60s. In one of our conversations, she told me about some of her biggest fears, that she still has to shave. And she said, I don't want to have fair hair on my face when I die. In the same conversation, she told me about some of her other fears, that she didn't want to be buried as a man with a man's name. Think about the forms and some of the questions you've asked or heard. Where would there be space for Janelle to share this type of information? And would she have even felt safe to share? Because if patients can't share certain things, it's really hard to have these things. Now more than ever, we in healthcare need to be aware of how much our communication matters. Written communication like forms and letters, websites, spoken communication like intake forms and conversations with patients. All of them can show that we're open and welcoming to people who are LGBTQ. It matters at the individual level and also at the organizational level. Your team, your clinic, your office, your institution, and also your community. Simple things help a lot. Signs, buttons, pins. Signs to let people know that they're safe. Do ask, do tell. We ask because we care. It might not seem like much, these signs and symbols, but they all send a message that you're safe and you care. And I'm not saying that hanging a sign or putting on a pin is going to solve all of this. But what they are doing is communicating. And in this current era of don't ask, don't tell, these things carry a lot of weight and meaning for people who are looking for them and to know that they're safe. And LGBTQ people are pros at looking for clues, no matter how small, to know that it's safe. They've been doing it their whole lives. It was one of the only ways to know if someone was safe, because you had to know who was safe and who wasn't. And this hasn't changed. But it becomes critical for people who are older, especially when they're dealing with serious illness or chronic health issues or end of life, which is often times when they need to go into assisted living or need extra help. Assisted living communities are actually one place where stigma and discrimination are a major problem. As I mentioned earlier, many LGBTQ people don't come out until their 70s or 80s, if ever. And if they do come out, 75% go back into the closet when they enter long-term care. 75%. About 2 years ago, we got a grant to do some trainings at six Denver-based assisted living communities in Colorado. The goal was to help them become more inclusive to LGBTQ residents and staff. And even though this was a community-initiated grant, meaning it really came out of the community, we got a lot of pushback from leadership. We couldn't say the acronym LGBT. We couldn't use a rainbow on any of our materials. Leadership told us that there was no need for the training because they believed they didn't have these types of residents in their communities. After a year of going back and forth, and at this point I was getting a little annoyed, they gave me 45 minutes to go into these communities and tell them about the project. So as a researcher, I was like, bring it. I am going to show you how hard it is for LGBTQ people in these communities so that they understand. So I shared terrible statistics, some of them that I've shared this morning, about how LGBTQ people are treated, their fear in healthcare, their discrimination, their silence, including in assisted living communities. I'd tell them about the stress and the discrimination, how LGBTQ people lose up to 12 years off their life because of it. All of it, and nothing. It was like all the data just floated right past them, no impact at all. Every once in a while, I'd get a question. I remember one person asked, why would anyone choose this lifestyle if they knew they were going to lose 12 years? Another person asked if there'd be less gays now that more people are eating organic food. My message was not getting through. No one could see that these were real people behind the numbers and the statistics. And some of the people lived with them, took care of them, or worked with them. After the organic comment, I drove home realizing I needed a different strategy. These numbers and statistics were too abstract. I needed to break open the single story and the stereotypes that had cemented in their heads, stories that were incomplete. I needed to figure out how people could see that these were real people that were being impacted by these statistics and these disparities, people that were in their communities. When I told someone I work with about the organic comment, she asked if I got mad or yelled back at the woman how ridiculous that was. And in my head, I was thinking, how the heck am I going to yell at someone who's 70? And what good would that do anyway? No, I said, I was just quiet. I let her finish. Because the truth is, I'm in those communities to listen as much as to talk. I needed to understand what was bothering them, what was getting in the way, and what they were afraid of. How else am I going to understand what they were actually worried about? And how else was I going to meet them where they were so that we could actually do these trainings? I think the organic woman was truly convinced that she'd never met anyone who was gay, even though I was in the room with her. And all she had were stereotypes. And here I come throwing all these statistics around about LGBTQ people. She could not picture the people I was talking about, people like Esther and Shirley. There was no link for her to make, zero connection. That night, I reached out to 30 LGBTQ women who I'd interviewed for another project and asked if I could take their picture. I thought maybe it'd make a difference if people could just look LGBTQ people in the eye, see for themselves that there are real people being impacted by these disparities, people who look just like their sister, their cousin, their neighbor. And they all said yes. I had no idea what I would do with these photos, but I showed a couple of them to some friends, one of whom ran the Bioethics Center, the Humanities Center at the School of Medicine in Colorado, and the other who organized art exhibits. And they loved it. So a month later, we installed the exhibit and decided to call it Eye to Eye, Portraits of Pride, Strength, and Beauty, because we hung the photos so you'd look right into the eyes of these women. Eye to Eye, which has 27 black and white portraits of older LGBTQ women, has now traveled around the state of Colorado, to churches, to art galleries, to libraries, and has been featured in news stories, including the USA Today. I've been doing research for a long time, and probably 10 people have read my articles in top journals. Most of those 10 are probably my students. But hundreds have seen this exhibit, and hundreds more have read stories about articles about this exhibit and these women. Stories of hope, of beauty, of courage of LGBTQ people. Stories that help humanize this community. And the exhibit is still going. It's going to be hung at the Denver International Airport this summer. It's wild. And every time I hang this exhibit and the news stories start, I'm like, who would have thought that these 27 photos I took during COVID out of pure frustration could do what I've been trying to make happen for 14 years as a researcher, connect data and people. I'm not suggesting that everyone run out and create a photo exhibit, but I am saying that stories are a powerful way to unravel stigma and illustrate what we mean when we talk about disparities. Real world examples help people see the individual, and how it impacts their lives on a daily basis. I hope some of the stories I've shared this morning, this afternoon, or evening, wherever you are, about Esther and Kathy and Janelle stay with you. And I hope you remember that this habit of silence has existed for decades and still affects the way LGBTQ people move through the world. And it won't go away unless we all start pushing back and breaking open these scripts, opening up space in our conversations with families, friends, patients, colleagues. We have to be proactive here at every level and every interaction, because the fear right now is real for LGBTQ people. And fear is a huge barrier to having a healthcare system where all can thrive. I've actually heard the word fear so much recently, I looked up the definition for this talk. It's an unpleasant emotion caused by the belief that someone or something is dangerous, likely to cause pain or a threat. After hearing the stories of hundreds of LGBTQ people and looking at the data, I've come to understand how much fear has contributed and still contributes to their health and to their care. Unraveling this fear through communication is one way to rebuild a healthcare system where more people can actually thrive. Every LGBTQ person I've met in my research, they are not asking for a lot. They just want to be able to talk openly and be heard without prejudice. And thank you all for listening.
Thank you so much, Dr. Candrian. That was really impactful. And since you ended with Esther, I'm going to start with Esther because it really was powerful. And as medical decisions get made for people in the absence of their long-term partners, I think that is something that every ethicist finds incredibly concerning and seems to be not just individual or system, but structural in ways that there are various policies about who gets to make decisions for their loved ones, or how we determine if there's different disagreements between people about making healthcare decisions for someone who can't make it for themselves. And the Minnesota is in the process of establishing a default surrogate decision maker for healthcare law, and defines it as a kinship structure. That is friends or kinship structure, which seems quite inclusive. But I'm curious your thoughts, your reflections on the idea of creating within law this idea that will socialize the idea that it is not that family has very different meanings for many people.
I think it's excellent and exciting, and exactly what you said, just to continue to really, it's systematized that people's person oftentimes aren't biological, and to not default to that, and to really give space to have these conversations differently, and then being able to actually legally recognize other types of families. I think it actually speaks volumes to what we're trying to do and help really normalize that people rely on different people to make decisions and be with them when they need it the most. And to be able to have something as secure as legislation, I would add a huge amount of safety and relief to LGBTQ people. And hopefully, that will be models for other states to follow.
And I think socializing the legislation to the boots on the ground providers to recognize that, I think, is a really critical piece as well. And I would also like to encourage any attendees to submit questions in the Q&A at this point. And we do have some questions that were submitted ahead of time. And a number of them really talked about how do people bring impact. So the small things that are meaningful, signage, pins, being welcoming. How about beyond that? What do committed people who are troubled by this, who work in healthcare, do?
I won't repeat the signs and the symbols, but I think just to underscore really, though, this is not just throwing on a pin, but it does, like, the more ways we're able to show that we're safe really really matter. I think, and depending on context, I mean, one thing we've done in Colorado with assisted living communities is just to start also creating places. We actually call them brave places because you can't always guarantee safety, but just starting groups where you are bringing people together, because we know with fear creates more isolation and to be out, but really being intentional and deliberate about having spaces where people can come together, whether it's just, to be together, to share information and just be in community safely is a huge protective factor right now. I mean, it's always been a protective factor, but really thinking about how all the ways we can bring people together in community to continue to serve as a protective factor for, physical and mental health and just isolation. And
Yeah.
the communication is also critical. I think we underestimate how powerful, maybe not always underestimate, but how powerful it can be to just let people feel like they can actually, answer questions in a way that really fits them and their experience.
How about your thoughts about advanced directives and kind of documenting one's wishes ahead of time for people who are in situations like this where they are concerned about decision making should they become incapacitated in their partner?
Mhm.
Um, are there processes by which people are really enacting that in anticipation of the fear that's coming?
Yes, and this is, I think, been just historically for LGBTQ people feeling like they have, multiple forms and multiple needs to document. And I think now that things are so different state to state, of really making sure these are updated, that these are transferable if were to get sick in another state or travel to another state. And I think too, just, I mean, also not, letting the information also lives in conversation. So the forms are essential, and also making sure these are documented in as many places to as many people as possible, I think are also, I mean, they're extra steps that LGBTQ people often do and are used to doing. And now more than ever, knowing these things are documented, where they work, where they don't work, and also continuing, to bring them up in the conversation with not just healthcare professionals, but with, your friends and your community and the
Right.
people you call family.
Right. Um, Curious about or if you could share with us about intersectionality in this community and end of life and um, unique needs of particular, subsets of the LGBTQ community.
Yeah. I mean, it's hard to think about the work without the intersections and just how much harder than it becomes. I mean, I think with all those statistics, you could add on, it's 2 to 3 times more, 2 to 3 times more difficult with if you add race or ethnicity or disability or language. I mean, all these things just continue to magnify and exacerbate the disparities. And I think one thing that has also been thinking we've been thinking about is also just how addressing problems more from an intersectional lens. I mean, a lot of the way we think about policies and programs are often designed for one specific identity, but thinking too, what would it look like and really mean to begin to think about programs and policies that actually connected some of these intersections when you add in, aging and sexual orientation, race, disability, etc.
Right, right.
Really thinking across the intersectional continuum.
Would you mind putting up the slide one more time of the kind of statements is that you have and reflecting on those a little bit as far as how to genuinely approach these questions with curiosity in our current healthcare environment that really doesn't lend itself to the establishment of relationships with the majority of healthcare providers you see regularly. Um, and you mentioned palliative care and how those conversations really can get at many of these. But for the hospitalist caring or the oncologist who's caring for Kathy as she's dying, being able to really engage some of these next steps beyond these questions to really help facilitate that communication.
Next steps beyond this.
Going beyond these questions to really getting at the values and how to incorporate the answers to these questions in the way you care for the patient.
One of the things I do like about these questions, and we've used them, and is that anyone can answer them. It's not like it's not just for LGBTQ people, but everyone can answer these. So it's also they're effective insofar as that they are not just designed for one particular group. And I think what they also do is leading to the next thing is just begin to create some space and trust in the conversation to know that, okay, I don't need to talk about a husband or wife or kids. I can talk about, so already giving the space to then hopefully let them share other information. And I think with the documentation, I think then, is that what you're just where does it lead to? I think knowing that the stay is part of the conversation, that, Esther's person is Kathy. It's important that she's in the room. Just beginning to normalize those conversations, I think, are a great next step with these questions, so that, people start hearing, oh, it's Esther and Kathy, or that, this is their friend is the person who needs to be in the room. Just to begin to sort of hear these different scripts and know that they carry just the same amount of weight.
Right. And I think too, the idea of using stories reflects back to providers that every person presenting with cancer or with a heart attack actually has a story, and that it is, so much more beyond that initial medical encounter. And, I speak about it more in the inpatient setting because that's where we're most familiar, but I certainly in the outpatient setting as well, it should be as much part of someone's conversation as, how they're doing on their antihypertensive medications and things like that. So,
like with Janelle, her story always is so powerful for me, because it's, thinking about some of those forms or the way we've sort of traditionally documented advanced care planning, there is no space where Janelle could have, and that was her big, like, I just want to make sure someone asks or helps me shave my face, and thinking that was actually what mattered most to her. And nowhere sort of in a lot of our ways of talking and documenting would there really have been space for her to say.
Right. But the fact that she could reveal it to you reflects the need to express it, but inability to do so in the environment in which she needed to express it. So, I'm trying to think about how to ask this question, but the marriage between data and stories. I'm curious what happened with the assisted living folks after you left that first meeting frustrated, and how you've modified your approach to how you communicate about this. Clearly, the photo exhibit is the communicative device in many ways, but follow up from that experience you had with the assisted living leaders?
Yeah, they're still very close partners. I work with them a lot. They actually added belonging as a core value after the work, and we ended up doing learning circles, which actually, which was not at all our intention. We had these plans to do this like rollout training, and it was great though, because we brought, we listened to them, what they wanted, what would make sense, and it was a really great way. We made actually a short video with them and actual residents and staff who were in their communities, so people could hear their stories. It was just a 20-minute video, and then we opened it up for learning circles. So it was really nice, actually. It was really effective, and then they ended up having to become a core value, which was really great. And I think having been on Capitol Hill this last year, really hearing data and stories and being able, I think we as researchers have such an opportunity to really use research to give voice to a lot of different issues and help people reconnect in new ways. I mean, there's what's happening with policies and the way it really impacts. There's still such a disconnection between, what 16 million people without health insurance might look like for, someone who will be on the street. So really, I think using data and stories in a way that really helps people connect has certainly been a passion of mine.
And someone brought up in the chat that it's a bit of a catch-22 because, as they say, visibility is dangerous right now.
Right.
And any thoughts or ideas you have as far as approaches right now to be able to tell these stories effectively?
Yeah, I mean, that is like the catch. I mean, how do you advocate for collecting sexual orientation, gender identity, knowing that it's complete grounds for possible discrimination? I think, I mean, what has I keep coming back to is, help. And I think this is where we need everyone to speak up who feels like they can, is also, making sure they obviously feel safe to share their perspective, and letting others who feel potentially like that they feel a little bit safer to also speak up more than ever. And I think, though, that it's critical, knowing how dangerous it is to be out, that we don't go away, and we continue to sort of break opens and create openings in places where we know might be a little bit safer, and also being intentional about where we do it and when we do it. And I think there's still a lot of opportunity to do that right now. I think it has changed and has stopped me from doing a lot of things, but there's still really finding people where we can make these changes, where we can tell these stories, and holding on to those and staying with them for now until the tides turn.
Yeah. And I think there's so much effort in really respecting people's need for privacy right now that it has become challenging. Anybody doing qualitative work, I think, is pretty familiar with that. And it is just a new struggle for the work you're doing, that not a new struggle, but a confounded struggle, I would say.
Yes.
Interesting question. Someone asked about people who do virtual work with LGBTQ clients and ways in which they could be more welcoming.
Oh, that's an excellent question. I think before, when Zoom and everyone had their pronouns, which was so nice to see, they're still nice to see and really critical, of course. I mean, that using the correct pronouns is really critical, adding them to your signature. And I think they're, whether it's something behind your office you could have up. Again, I always look for those signs behind desks, or offices, wherever you are. So just those simple, subtle things. And then asking about someone, if someone has a partner, asking how their partner is, or how they are continuing those conversations, and then using their language if they've talked about a partner or different things like that, can go a really long way to continue to show that, they're seen, they're valued and respected. I give those 3 recommendations.
Great. And do you know of any organizations or communities that have advocates that can go with people to medical appointments? Is that something that exists?
Wow, that is an excellent question. And it could be back to the first question about what can people do right now. That would be remarkable. I mean, I know they have different navigator programs. No, I think Sage would be the best, but the best resource. And I've included them. I know they're local chapters, but Sage National, think about what that might look like, or even exist, or even I know Minnesota, you all have, I know not everyone is in Minnesota, but have great local LGBTQ organizations. But that's an excellent idea. I mean, that would be be huge. But I would look at Sage, and then your local groups, and if not, start that, please.
Someone was asking about, even with advanced directives, power of attorney forms, oftentimes when there's disputes over who may be an appropriate decision maker, that biological family that may not be listed as a preferred decision maker by the patient may enter the picture. And while they may not have decisional power, they've rejected their person or not been participatory. And oftentimes someone was just commenting that it makes ethics consults so difficult because this is now at the end of life when closure is desired by many for things that have been lifelong conflicts. And so I think it's just really pointing to the importance of documenting preferences. And you've highlighted to us that those preference forms should certainly be inclusive. But that there are frequently times where differences of opinion between people have much more to do with history than the current situation. And so, and just ensuring that we provide the opportunity for people to tell us in advance. I think that's probably a very good action item for people who want to make a difference, is helping facilitate completion of kind of goals and values so that it's documented for people. So, and a number of people were asking about, someone asked if you have advice for advocacy without disclosure. For example, if Esther had told a safe provider but didn't want the rest of the team to know.
What, can you say the first part? So what is it?
And do you have advice for advocacy without full disclosure? For example, if Esther had told a safe provider but didn't want the rest of the team to know.
I'm really glad someone asked that. And I think that happens a lot. And I think just also, if this information is told, who following up with, is it okay if I share with the rest of the team, or is it okay if I share with other people, is really important, because some people either won't feel trustworthy with other people or just feel like they can tell one person. And I think too, there's such a burden to always be coming out over and over, and then when you're sick and exhausted and tired, that to having to keep doing it, that once you find one person can really be everything for someone. And so I think following up and making sure, what should you do with this information? Do you want it in their chart? Do you want it in their notes? Do you want the team to know, or just this person? I think are totally reasonable questions, and important questions to really be an advocate for someone, and a safe advocate.
And curious your thoughts about how to incorporate this into medical education, into training. Certainly there are curricula in medical schools, but likely not curricula that share stories like Esther and Janelle. So tell us how you approach it.
As any opening I can get, I will add an Esther or a Janelle, because I think those stories just begin to, again, just give people different vocabulary, normalize these vocabularies, just sort of really bring attention to the way we. And I think another important, like, these questions are just, they can be unconscious. Like, we sometimes aren't even aware of how they might really box people in, and I think also just these questions actually, and knowing like this feels like containable 5 questions to just think about. And even if, asking people to just maybe try one out feels like a win right now. And I think from an education perspective, really redefining winning, but also just thinking about different moments to add things in, as opposed to, like an entire curriculum on LGBTQ people, but how can we get some of this information into the existing curriculum has been sort of my new approach, which comes down to really, reaching out to people, having relationships, and expressing the need and the importance, and then offering to share some of these stories or provide a little bit of content here and there can go a long way. So instead of trying to make like big robust changes, is what we can do
Right.
within the system.
Yeah, and I think that's very appreciated. And for everyone who's sort of overwhelmed after hearing this about wanting to do something, I think that's probably the take-home message, is that it doesn't have to be enormous legislation. It is really subtle differences in the way you approach communication, interaction, probably even your physical presence in many ways. And that just the awareness. And I want to just tell you how much I think this is appreciated by everyone in the chat, that just calling attention to this in this way, I think then allows people to really consider it in a different light. And while there should be a recognition that everyone is a person, not just a number, I think this really does bring it very close at hand, and gives practical opportunities for people who are committed to just doing better. So I thank you so much, Dr. Candrian. Any closing comments or?
No, I mean, thank you all so much. And that's exactly my hope, is that, it can feel daunting to where do you begin, or, feeling like we have to pass legislation, which is really hard to legislate how people think and feel. But there's so much we can really do. And to, like, this habit of silence is real and it's getting worse. And to know that we actually have a lot of control and opportunity to really let people feel different with our conversations. So thank you.
Thank you so much. And I just want to share a couple upcoming webinars we have from the center. So in May, we'll hear from Dr. Jennifer Tsai about race matters in education research and practice. Joel Wu from our center will be doing our Unpacking Bedside Bioethics in June about first person authorization and organ donation. And we will have Jason Wasserman in August for another Unpacking Bedside Bioethics, speaking about codes. And then for those of you in Minnesota and those of you who are students here, we just want to promote our courses for the fall. So Dr. Connor Menzies and Joel Wu will teach biomedical ethics, and Dr. DeBruin and myself will be teaching a course on social justice and bioethics, and they're both virtual courses. And here is the QR code. It will also be in your presentation details document, should you be interested in registering for these courses in the fall. So again, I just want to express my true appreciation for your work and for meeting with us today, Dr. Candrian. Thank you to everyone who attended. And again, you will receive an email, and which will also include the resources from Dr. Candrian's presentation. So thank you so much, everyone, and I wish everyone a lovely weekend.
Thank you.
Thank you.